Thank you, ladies and gentlemen. We've had two excellent talks, and it's my privilege to give this plenary talk. So, I'm going to talk about genetics of diabetes, and you can see from the title, it's going to be slightly different from what I normally do. Normally, we talk about monogenic diabetes, single gene producing a disease, and polygenic. The concept of oligogenic has also come, and I'll try to introduce that to you. I have no declaration of no conflict of interest to declare. Any of my studies on genomics will not be possible without my group, headed by Radha Venkateshan, the lady in the black sari, and she's been working with me now for 25 years. And her department alone has produced 150, only on genomics, 150 top quality publications, including some in Nature Genetics, and 16 PhDs. Another 4 or 5 are now doing. So that's the output. So I'm only a postman showing you their work. So when you talk about genomics of diabetes, of course, polygenic diabetes is the most well-known, and both type 1 and type 2, which comprise, add together, it's about 98% of all diabetes, are both polygenic. And what it means is that there are multiple genes involved. None of those genes are causative. They're all associations. The more genes you have, and you're talking about 150 genes and 700 genes for type 2 diabetes, and type 1 also many. Now we have polygenic risk scores, and if you do all that, you can predict when the child is born whether diabetes will come and so on. The problem with polygenic is none of them are causative. They don't cause the disease. They only promote your chance of getting diabetes. And then there's a huge environmental component both for type 1 and type 2. That's why it's called polygenic. Okay? So as I said, there are more than 700 genes, and if you look at, this is from chromosome 1 to 22, if you look at it, in every chromosome, there are several genes which are variants which are associated with type 2 diabetes, and the list is growing. But I don't think any more genome studies will pick up whatever we have to find out. We might find one or two more, but from 100, 200, 400, now it's reached 700. I think we are kind of saturated as far as gene discovery is concerned. Now, the point that you have to note is that of all the studies which have been done, all the 700 variants which have been described, the majority are either for beta cell dysfunction or decreased beta cell mass. There's only one for obesity, which is the fat FTO gene, and then there are a couple for PPARG and a few others for insulin resistance. Almost all the genetics is for insulin deficiency and insulin and beta cell mass, beta cell function, so everything related to the pancreas and the beta cell. Now, this is one of the first genome-wide association studies which we published in Nature Genetics. And what was good about this was that 6 novel genes associated in South Asians, Indians, Pakistanis, and Bangladeshis, and all of them are co-authors in this, but not in Chinese, Japanese, white Europeans, or any other population. So definitely there are genes associated with South Asians which are associated with type 2 diabetes. And you can say, oh, you've solved the problem. No, we haven't solved the problem, because the association of those genes is so small that if you had all the 6 genes put together, it will be 2% of why we get diabetes. So it really doesn't explain why we have this epidemic of diabetes. There are 3 more GWASs, and we have been involved in all the GWAS studies published, including one from India itself by Nikhil Tandon and Dwaipan Bharadwaj. This is more recent, and we looked at, can we explain the South Asians? And when you study South Asians, Indians, Pakistanis, Bangladeshis, you need a control group. So many of the studies we can't do in India because we have only Indians here. We can't have a comparative. So we always have a comparative group in Europe to do that. This is a recent study which both with Scotland as well as with London, which we published. And this is part of my Kelly West lecture, which is just published. So what we clearly show is that if you look at the genes for beta cell function, these are partition polygenic risk scores. So you put all the genes which I showed you for beta cell function, and you study them in large numbers of Europeans, white Europeans, and in South Asians, they are separating out. So we are able to show that the South Asians are actually separate, and that's why they're getting it at a younger age, and that's why they're getting it when you're much thinner. You don't need obesity to get it, and that's clearly coming out from this, and more studies are getting published now. Now let me move on to oligogenic and digenic. So what does this mean? Polygenic, I showed you all those genes, okay? Now none of those genes are causative. But then at the other end of the spectrum, you have monogenic diabetes. And as the name itself implies, it's only one gene, only one mutation is enough to cause the disease. It's causing it. If you don't have that mutation, you won't get the disease. If you have that mutation, you will get the disease, 100%. So life is very simple when you said it's polygenic and monogenic. But today what you're finding is that the monogenic diabetes is about 100%, almost 100% penetrance. But then we started finding some monogenic people who have it, but the penetrance is not so good. And then we find that some of these monogenic genes are also present in type 2 diabetes. So that's where it becomes oligogenic. And this is a new term which has been explored, and we call it as recognition of oligogenic forms of diabetes. And so if you clearly divide it, this is the type 2 diabetes which I showed you in the blue bubble at the bottom. There in the green bubble on top is the monogenic diabetes. So life used to be simple when you could separate those two. But then in the middle are all these oligogenic diabetes. Now these are genes which have been associated with monogenic diabetes. But their frequency in any monogenic diabetes gene, whether it's HNF1 alpha or any of the neonatal genes, it should be less than 1 lakh population. If you do 1 lakh people, less than 1 in that should have it. Only then it's a rare variant which is associated. But now you're seeing the oligogenic genes where some of these genes are common to both type 2 diabetes as well as monogenic diabetes. And then these Lord scores, which are very small, which I'm telling you, in the oligogenic, they're getting almost to the monogenic level. So it looks as if this is an artificial separation, the monogenic and the oligogenic. And these are examples of oligogenic genes. About 10 or 12 have been described, which can occur in monogenic diabetes, but they occur in polygenic diabetes, and they are almost like a causal kind of a gene. So we're beginning to understand much more about the polygenic diabetes. And you can show in this cartoon that monogenic is separate and polygenic is separate, but then you have these oligogenic genes which are both in monogenic as well as in polygenic. To a person like me who has been doing research on genomics for at least 25 to 30 years now, getting confusing. I think the boundaries are kind of blurring, and you can't just simply say that that's how science develops. You cannot just bucket everybody into something. Human beings are so complex that to understand this biology is very difficult. But let me move on to monogenic diabetes in the interest of time, because much more exciting and much more clinical is the monogenic. Now, in the monogenic itself, to cover the whole of monogenic diabetes is very difficult. We are the National Center for Monogenic Diabetes in India. We are today an ICMR collaborating center, and we service more than 150 medical colleges in this country. Almost from every city in the nation, we get samples. Almost every day, we get 3 or 4 samples. And the good news is that we're doing it almost completely free of cost now. So the budget is huge, but we put in our own resources, and we are able to don't even get ICMR funding now, but we are completely doing it free of cost to the nation. So if any of you has a suspected case of monogenic diabetes, please send it to us and we'll do it to you free of cost. In 2 weeks, we'll give you the results. We'll tell you what to do with it as well. So there are a number of monogenic diabetes, and it's a very complex subject. I'll only talk about 2, MODY and neonatal diabetes. So MODY, when it was first described, and I have another good news to tell you, my absolute hero in medicine from the time I grew up, because I read the first paper of Fayance and Tattersall when they described MODY in 1975, when I was in final year of medicine, by which time I was already 3 years into diabetes research. So when I read that paper, that got imprinted in my mind, and from that day, Stefan Fayance was my hero. And the beginning of this year, I was telling my secretaries, now there's a Stefan Fayance Institute in the University of Michigan, which I've never gone to. I want to go and stand and take a picture, because I knew him very well. He used to write to me, and till the age of 93, he was publishing. So I said, my ultimate dream is to go and stand there and take a picture in that institute. And a week later, I get a letter from the University of from the University of Michigan, saying that we have a Stefan Fayance lecture, which we would like you to deliver. And you'll be the first non-American to deliver this. And I said, oh my God, I was discussing with Jibin yesterday that when we think of something, it just happens. Don't ask me how. Anyway, MODY is now classified into different types. The red ones have been removed. They are no longer MODY. We have been working on this for many, many years now. MODY 3, we have a series, MODY 1, MODY 2, MODY 5. And then we did a comprehensive genetic analysis where we picked up some new MODY genes in India. But only some forms of MODY. Why are we interested in this MODY? Because they are wrongly diagnosed as type 1 diabetes and given lifelong insulin when they should not be taking insulin at all. So how do we identify that? A young person comes in and everybody who stands for genetic testing, it's not cost effective. Nobody can do it. You know, there are 1.4 billion people in India and you can't be testing everyone for genetics. So you have to find out who to test because only three, the MODY 3, MODY 1, that is HNF1 alpha, 4 alpha and ABCC8. ABCC8, we found out that they respond to tablets. So only these three respond to sulfonylurea. How do we pick up these three? So that was a project of, this is what I call as actionable MODY. So one of my PhD students, Aarti Ramaswamy, we put her on the job and we said, you go through every proven case of MODY through ACMG criteria, NOMAD criteria, every criteria in the world accepted as MODY. And then let's see how, from an electronic record of 6.6 lakh people that we have, we can pick out those MODY cases using clinically. It was a big job. It took us 3-4 years to do it. So we took up 34 cases, absolutely, Andrew Hattersley, nobody will argue that this is not MODY. Then took a large number of type 2s and type 1s as controls, used various clinical parameters. Can we use age, can we use BMI, HbA1c, HDL cholesterol. Finally, we hit it by doing the fasting C-peptide, shown there, and the stimulated C-peptide shown there. The blue is type 1, the green is type 2, and the red is MODY. So they kind of come in between. If you now give me a report of a C-peptide from my lab, I can definitely tell you whether it's worth looking for MODY in that series or not, just by looking at the result. I can say this cannot be MODY, this cannot be MODY. If the C-peptide is absent, it's type 1. You don't even have to look at it. And many of the referrals which you guys send me are classical type 1. Don't send those samples to me if they're GAD positive and so on. So if you look at the sensitivity and the specificity of the stimulated C-peptide, it's almost coming to 96% sensitivity and 100% specificity. The fasting is not that good. But to the stimulated C-peptide, what is stimulated? Take a breakfast, 90 minutes later, take one sample. So simple, 300 rupees, the test costs. And with that, we can roughly say at least who to send for genetic testing. Let me now move on in the remaining 7 minutes, 54 seconds that I have to neonatal diabetes. If MODY was exciting, neonatal diabetes takes my breath away. In fact, everyone who refers patients to me, and my largest referral is from Professor Raghupati, who was in Vellore and now in Bangalore, Manipal Hospital. So he tells me, Mohan, every time I send a sample to you, I pray and then send the sample. Because if you find a mutation, the child goes off insulin. If you say there's no mutation, gone. The child is on insulin. So that is what is neonatal diabetes, diagnosed before 6 months of age. Now, if I tell you a story, it'll be more compelling. 3-month-old baby, Ivana Das, my father, mother said, use her name. From Calcutta, she came. She was diagnosed 15 days after birth, newborn baby, okay? And she was on insulin, not controlled, and a Calcutta physician said, go to Chennai and give your sample there. So we did it, and then we found that this child had the KCNJ11. There are 2 mutations, the KCNJ11 and the ABCC8, which respond to sulfonylurea. There are neonatal diabetes like GATA mutation and insulin gene mutation which do not respond. They love to continue insulin. So every child below 6 months, please don't stop insulin and try sulfonylurea. 50% children will die. So please don't do that without a genetic testing. You say, oh, but it's expensive. It's zero cost. I'll do it for you without 1 paisa being spent. Just send it to us and we'll do it to you. Any number, just keep sending it. My personal contributions take care of that. So if you do that, here's this child, what happened is sulfonylurea dose increased. She was admitted because she's the first patient we treated, and then the insulin dose came down, and you can see the sugars not controlled while on insulin. As the sulfonylurea went up, it came down. I say, okay, maybe for a few days she responded and you're making a big joke of this and so on. No, she came back later, and of course we had a lot of excitement for that. This was when she first came in 2014 to me, and that's how I looked in 2014. And her baby, her mother carrying her, we have switched her off, we've taken her off insulin. I was happy to see her in 2023 when Andrew Hattersley also visited us again. 9 years later, she has not had 1 injection of insulin, not even 1, after she left our hospital. She's completely controlled. Her HbA1c is 5.8. She does not even do self-monitoring. She says, my sugars are well controlled, I don't need. She just goes every 3 months to our Calcutta branch, does free treatment there, free A1C, and she just takes half a tablet of glibenclamide in the morning and half a tablet of glibenclamide at night. That's it, 9 years. You may say, okay, what did she benefit? What she benefited is this. If the genetic testing was not done, if she was not referred to our center, if we did not do the genetic testing, she would have been 9 years, now another year has passed. 13,140 times she would have injected herself, okay, unnecessarily, and shouldn't have had a control. That would have cost her 1,75,000 if you use the cheapest insulin available. Glucose monitoring she would have had to do, she was on insulin. 2.58 lakhs she would have spent. Her father's income is 20,000 rupees per month. Okay? So there's no way she can afford even tablets, leave alone insulin. Thanks to genetic testing, 13,000 injections gone. Cost of the neonatal diabetes testing is 2,000 rupees. Of course, we don't charge her for it, so she did it free. Cost of sulfonylurea, which she buys, is 6,000 rupees for 9 years that she has taken. Okay, and the total amount spent is 6,000 rupees over 9 years. You divide that per year or per month. So that's a cost. If genetic testing is not done, she'd have been on insulin even today. Because we have had large numbers of neonatal diabetes cases. You can see the dramatic transition when they are on insulin. Look at the A1Cs. Look at the A1Cs once they've changed to sulfonylurea. This is just the first report. Now we have very large numbers. You can see how the A1C comes down. And we have follow-up now for second year, third year, fourth year, fifth year. We are following up all these children. So we created this registry of monogenic diabetes. And if you just Google or you go to internet and you just type www.monogenicdiabetes.in, IN is for India, you will get how to send the blood sample, how to take the consent form. Just send us a blood sample. It will even give you the phone numbers, how to ring and our email IDs and so on. Today I'm happy to tell you that the list is growing from every part, from Dibrugarh to Srinagar to every part. I'm sure all of you, many in the audience would have sent us samples, and we are continuously increasing the speed of the testing and the quality of the testing. And today we have covered close to 2,300, this may not be updated, 2,300, of which 1,300 are MODY, 414 are neonatal diabetes, congenital hypoglycemia, the opposite of neonatal diabetes, where they get hypoglycemia from birth and they can get fits and they can die. Earlier, those children used to be sent for pancreatectomy, subtotal pancreatectomy. Today we stopped doing it because we know which child will respond to diazoxide, which child will respond to octreotide. We have created a genetic table now. Just looking at the gene, we'll say this child is for this and this child is for that. And All India Institute Delhi is one of our largest referrals. They keep on referring every child. Institute of Child Health Delhi, Chennai, the government institute, every day at least 1 or 2 cases will come from there, and the list is growing. So here is an appeal to you. There are thousands of neonates. If you look at the number, there are thousands of neonates with neonatal diabetes in India. Why are we having only 400? If you had the other 400 with genetic syndromes, let's say 1,000 cases. I believe there must be at least 10,000 or 20,000 children. Many of them will be dying because they're not even diagnosed. When a child gets fits or gets into a coma due to high sugar, they don't check the blood sugar. They check everything else. They'll do scan and they'll do LP and they'll do all kinds of things, but they don't do blood sugar. A blood sugar is like 20 rupees. 5 seconds. Just put in a glucometer. That is enough. You'll pick up low sugar or high sugar. Having diagnosed that, let us have a national campaign to pick up our children. Because here is the greatest miracle of diabetes, in my opinion. If discovery of insulin was a great discovery of the century, I think picking up neonatal diabetes and taking children away from insulin is also nothing short of a miracle. Why don't you help us to find these children, and we'll do it free of cost for you. If you just scan that code, it will tell you how to take the sample, where to send it, how to send it. Encourage all of you to take a picture of that and call Dr. Radha Venkateshan or me, and we are happy to do this. This is my lifetime mission. For the rest of life on my planet, I want to find all these children and try to help them. And even from neighboring countries, Bangladesh or from Pakistan or Sri Lanka, Nepal, all of you are in the audience, please look for these children and take them off insulin. Let them all become like Ivana Das. Those are my contact details, and these are my social media. And finally, I have a WhatsApp channel. So if you're not joined me on WhatsApp channel, please again scan that, because this will also tell you how to, something new that we are doing at our center, we will reach out to you, because I want to spread the message. I don't have too much of time on this planet, and therefore whatever else time that I want to do, I want to make it useful so that we serve more and more people. And if we can have at least another 1,000 Ivana Dases in India and in this region whom we are able to take off insulin and change their lives, I think becoming a diabetologist, a decision which I took 50 years ago, will be justified. Thank you.